Hello, my name is Sean Gallagher, and I'm a childbirth educator, and welcome to the ChildbirthJoy Prenatal Class presentation on early labor. I would first start with saying that your healthcare provider, your registered midwife, your physician for your pregnancy is your primary source of information. You would always go with what your healthcare provider tells you. This presentation cannot begin to cover all of the ins and outs of various aspects of pregnancy care. So this information is given as general information. If you have any questions specifically, then always contact your healthcare provider for specific information. So let's get started. A little bit about me. I'm a childbirth educator. I've been doing this for quite some time. I was a registered midwife in Toronto for a while and one of the co-founders of Midwife Alliance in the West End of Toronto. I've also worked as a doula on and off throughout the years. And since 1999, I've been a board-certified hypnotist. I've been providing hypnosis sessions for a wide range of presenting issues and also doing the prenatal classes. So I specialize in childbirth, also for fertility, hypnosis, and a number of other areas. I am also an evidence-based birth instructor, one of the first in Ontario, and I will be providing more information that is evidence-based birth down the road. But for now, we're going to be covering just some of the basics in the field of information for early labor. For more information on my services, you can go to ChildbirthJoy.com, or I also have the website SeanGallagher.com. So as we take a look at early labor, I'm assuming a number of things here. I'm assuming low risk. So anybody who is between 37 and 42 completed weeks is what we call term. Anything before 37 completed weeks is considered preterm, and you would always contact your care provider. So this information is for those who are at term, 37 to 42 completed weeks. We're also assuming one baby, single baby, not twins or triplets, and that the baby is head down. So multiple births, twins or triplets, or breech births are considered more complex, and there are different sets of rules in regards to what's happening with the birth. So you would always go with your healthcare provider says. We're also assuming no significant medical complications, so no cardiac disease, no significant problems with diabetes, that kind of thing. And again, if you're under the care of an obstetrician because of high risk, then you would always go with what your obstetrician says. Generally speaking, family practice doctors and midwives are specialists in the low risk. And we're also assuming that the amniotic sac is intact. Small percentage of births start with the amniotic sac releasing, or what we call the bag breaking or the waters breaking. That's a small percent, usually under 10%. Usually the amniotic sac will release at some point during active labor. So we're not going to be talking about the amniotic sac releasing in this particular presentation because we're assuming that statistically it's most likely to release during active labor. Certainly if there is fluid leaking, then that's something that you would contact your care provider about. So assuming a number of things, term, single baby, baby head down, no medical complications, amniotic sac intact, then usually for most people this presentation and the kinds of things we cover is applicable. So if somebody has not reached 37 completed weeks and is having any kinds of contractions, whether they're 10 minutes, 15 minutes, 30 minutes apart, if they're regular, and or there's leaking fluid, and or she thinks something may be happening, it's really imperative that the healthcare provider be contacted immediately, regardless of the day or night. If preterm labor is happening, then it's something that can sometimes be stopped, especially if it's caught early. If something continues on for any length of time, usually 20-minute apart contractions get closer to every 15 minutes, 10 minutes, that kind of thing. And it's easier to stop 20-minute apart contractions than it is to stop 10-minute apart contractions. So always important to contact healthcare provider day or night as soon as possible. So moving on, Braxton Hicks contractions. So Braxton Hicks contractions are named after Dr. Braxton Hicks, who talked about them in the late 1700s. And generally, we think of them as normal uterine contractions. The body is actually doing Braxton Hicks contractions all the way through pregnancy. It's considered quite normal. And the nature of Braxton Hicks contractions is that they're quite irregular. So I've given an example here. Get one, another one 7 minutes later, 18 minutes later, 5 minutes later, 25 minutes later. That's quite irregular. They're kind of all over the map. Something that's every 10 minutes, 9 minutes, 10 minutes, 11 minutes, 8 minutes, 9 minutes, 10 minutes, then that would be considered fairly regular. And that's not a Braxton Hicks pattern. So irregularity is a hallmark of Braxton Hicks. You can't really kind of put a real pattern to them. They can be short, so they can be 30 seconds or a minute, but typically the ones that women notice are long. They might be 2, 3, 4, 5 minutes in length, and the belly is hard all over. If you're in later pregnancy and you can kind of feel the outline of your baby's back, say, your uterus will be quite firm in that area, but where you're not feeling your baby, if it's a bit more squishy and indentable, then that's not a Braxton Hicks. That's just you're feeling the firmness of the belly because the baby is there. But when you have a Braxton Hicks, uterus is hard all over. It's usually not noticeable as being crampy, especially for first-time moms. Second and subsequent time moms can usually comment on feeling crampy low down above the pubic bone. It's kind of the same place where you get menstrual cramps. So typically for first babies, you don't notice them that much because it's just the uterus getting hard all over. It's not crampy, and it doesn't stand out in any particular way. So as I mentioned, they happen all the way through pregnancy. Most women, especially having their first baby, don't even know they're getting them. But if you feel your uterus hard all over, that will be a sign that it's a Braxton Hicks. The nature of Braxton Hicks contractions, especially in the last month of pregnancy, is that they thin the cervix. So they start creating some changes to the cervix, which we'll talk about later. And some midwives refer to Braxton Hicks as toning contractions. So we think that there's some benefit to them in that it's sending more oxygen through the placenta to the baby. It's giving the baby a nice squeeze, so the baby will be familiar with being squeezed and hugged. Once the birth starts, it won't be an unusual thing for the baby, so the baby will be used to this. And this is just what the uterus loves to do. It's constantly contracting and relaxing its entire life. We just tend to not notice it, except, say, maybe with menstrual cramps, and then sometimes with Braxton Hicks. So certainly, if you're not sure about Braxton Hicks, you can contact your healthcare provider. Most women will comment that they'll have more Braxton Hicks at the end of a long day, especially if they've been on their feet all day. After female orgasm, Braxton Hicks are more common. Nipple stimulation will bring on more Braxton Hicks. Those are all normal. It's something that you want to be having happen throughout the pregnancy. Braxton Hicks throughout pregnancy are normal, and it's something that should be expected to happen. And the reason why I talk about Braxton Hicks is that they're different than early labor contractions. So as we move on to some of the signs of early labor, The cardinal sign is regular contractions. So they're different than Braxton Hicks in that they're regular. So they might be every 20 minutes, every 10 minutes, every 5 minutes, that kind of thing. So they have a regular nature to them. And like with the example I gave earlier, every 10 minutes, 9 minutes, 11 minutes, 10 minutes, that kind of thing. It's not something you set a watch to in terms of super regular, but it's roughly in that ballpark with that pattern. Some of the other signs of early labor can possibly include, but these don't define early labor. So you might also have these things happening at the same time where there's more frequent bowel movements, so the body is kind of clearing itself out. You may have a nesting instinct. You might feel like you need to organize or tidy or clean, that kind of thing. That's not uncommon. But you could have a nesting instinct and then go into labor 2 weeks later. So that's not a sign that you would just be taking as an important thing to define early labor as. The mucus plug, we'll talk about that in a bit. The mucus plug or vaginal discharge can mean something. It could not mean anything. Again, it varies. As I mentioned earlier, the amniotic sac can release prior to birth starting. It can release during early labor. It can release minutes before the baby's born. So that really varies. That's not, again, an absolute sign that early labor is happening. Some women, the bag can release and not go into labor for days. So it just really varies. A lot of books and websites will talk about pressure low in the pelvis. And again, all that usually means is that the baby is low. It doesn't necessarily mean you're going into labor. Somebody can be walking around in late pregnancy for weeks and the baby can be quite low and she can be feeling a lot of pressure. Doesn't necessarily mean labor's happening. And a lot of books and websites will talk about back pain. And when we talk about baby's position, not in this presentation, but baby's position is typically a reason why women will feel back pain. And ideally, your baby's in a good position and you're not really getting much in the way of back pain. But sometimes women will get back pain. It could mean something. It could mean nothing. So moving on, so as we talk about the contraction or the uterine surges, some people refer to them as rushes. There's different names for them these days. My training was to call them contractions, so that's typically what I refer to them as. So that they're every 5 minutes, or they may be more apart. So 5 minutes, 7 minutes, 10 minutes, 20 minutes, that kind of thing. Typically, they last 30 seconds, but they can last more commonly 60 seconds. They may even last a little longer, but typically they're every 5 minutes, lasting a minute. And they're mild. So if you're feeling anything, it's just kind of a crampy feeling in the lower part of the uterus, just above the pubic bone. And we talk about birth. We talk about the 3 stages of labor. First stage, second stage, and third stage. First stage, the cervix thins and opens from 0 centimeters to 10 centimeters. In the second stage of labor, the cervix is completely open at 10 centimeters, and that's typically when the body starts the process of pushing the baby down and birthing the baby. And then the third stage starts when the baby is born and the placenta is delivered. Right now, our focus is the first stage of labor, and the first stage of labor includes early labor plus active labor. So right now, we're talking about the first part of the first stage, which is early labor. Active labor is another presentation. So what's happening in early labor? Well, the cervix is thinning. The medical word for that is effacement. And with a first baby, there might be some opening of the cervix. The cervix is the lower part of the uterus. Sometimes they call it the neck of the uterus. And that's the part of the uterus that can be felt when a midwife or physician does a vaginal exam. Certainly you can feel your own cervix. The medical term, as I say, for thinning is called effacement. And with the first baby, you can have the cervix opening a little bit. It may open a half a centimeter, maybe a centimeter in early labor. For most women, for first baby, it opens maybe a half a centimeter. Usually it stays closed for the bulk of early labor. For second and subsequent babies, she may even have a cervix that's open to even 4 centimeters prior to labor starting. So the body can have a lot of changes in the last weeks of pregnancy, can open the cervix somewhat, and labor hasn't even started yet. So that's something to know. So the differences between first births and second and subsequent births can be quite significant in terms of what's happening before the birth starts and how the birth progresses. In general, we encourage you to think in terms of early labor as being warm-ups. So this is your body getting ready for what we call active labor, when things are really happening. And of course, in early labor, things are happening, but it's just think of them in terms of warm-ups. Your things are getting ready, getting prepared, but it's generally speaking not time to be contacting your healthcare provider. And I'll go over a bit more of that a little bit later. So, in terms of what's happening with the cervix, there's a lot happening in the body in regards to hormones like oxytocin and endorphins. There's a lot happening inside the body, but what we can kind of measure in a way is what's happening with the cervix. So the length of the cervix gets short, so it thins from 0 to 100% effaced. It'll get quite soft. It'll move from pointing towards the back of the mom's body to towards the front of her body. And it'll open from 0 centimeters. And in early labor with the first baby, it might open, as I said, half a centimeter, maybe 1 centimeter. For second subsequent babies, maybe 2 to 4 centimeters. In terms of the first stage of labor, the cervix is opening all the way to 10 centimeters. So you may be in late pregnancy, 39, 40 weeks. Your cervix has already done some great work. It's already thinned and softened. Maybe it's opened a little bit. The only way you can tell is to have your healthcare provider do a vaginal exam, and typically they will insert 2 fingers and just feel for the position of the cervix, how thin it is, how soft it is, and how open it may be. And that's done with a vaginal exam. So as we go to this slide for the effacement of the cervix, sometimes it can be helpful to just see visually. So as you see the top picture, the cervix is quite long and it's closed. And as it thins, it can be still completely closed. It can open a little bit. But the thinning of the cervix, it can get paper thin. Generally speaking, especially for first babies, once the cervix thins, then you move into active labor. Then it opens. Very unusual for first baby that somebody's been in early labor for a while and that the cervix opens in any significant way. We're talking about it thinning. The Bishop's score is an assessment of cervical ripeness. And the reason why I put this in is that it can be helpful to know your Bishop's score in late pregnancy. And the only way to know this is to have your healthcare provider do a vaginal exam anywhere from 36 to 41, 42 weeks, something like that. And it's scored out of 10. The Society of Obstetricians and Gynecologists, in their induction of labor guideline, recommends that if anybody is going to be induced in late pregnancy, so medical induction typically is with IV Pitocin, maybe with prostaglandin gel, maybe both, that there is a minimum of 6 or greater of Bishop's score out of 10. Because what they found is that if cervix is not ripe and somebody goes into labor, then usually things don't go that well. Usually it's what they call a failed induction that leads to cesarean. And so if anybody's going to be inducing labor, then what really is needed is a very ripe cervix with a Bishop score of 6 or higher. And in this slide, then what we're seeing is we're seeing how a Bishop score is identified. All midwives and all physicians who deliver babies know how to do a Bishop score. If you're getting a vaginal exam in late pregnancy, then ask your care provider before the vaginal exam is done, can you please just check what my Bishop score is, how ripe the cervix is, and they'll be able to give you that number. I've found in the past, if you ask your healthcare provider after the vaginal exam is done what the score is, then they'll kind of look at you blankly because they haven't really sort of fully assessed that. So you want to ask before the vaginal exam is done. Again, this might be helpful information if you get a vaginal exam at 39 weeks and the Bishop score is low, and then you get one at 40 weeks and it's gotten higher, then that's just interesting information. One of the important things I think it would be helpful to know that sometimes you see women who get a vaginal exam in late pregnancy and she's got a very ripe cervix, very thin, very stretchy, the baby's low down, that kind of thing. And a very ripe cervix can sometimes encourage people to think, oh, great, that means I'm going to be going into labor any minute now. And I would say no. It still could mean that the birth could happen a week or two down the road. A ripe cervix doesn't mean you're going into labor anytime soon. All it means is that when the labor starts, then things would be quick, generally speaking. A very unripe cervix, if somebody could have a very unripe cervix go into labor that night, typically should be looking at a long labor. And we'll talk about that in a bit. The other thing I'd mention about the Bishop score is the last point, station. And station refers to how low the baby's head is. And SP -3 or above refers to spines at -3 or above. 0 station is generally what we would call engaged. So the baby's head is low in the pelvis and is at 0 station or spines. And spines just refer to just these little nubby points in the pelvis. It's not to do with our spine. It's just, I don't know, somebody gave them that name, spines. And it's just these two little nubby bits in the pelvis that their healthcare provider can feel. So your midwife or physician can tell if your baby's at 0 station, -1, -2, -3, that kind of thing. And -1 means 1 centimeter above 0. -2 means 2 centimeters above 0. So -3, well, the baby's not all that. The baby's pretty high in the pelvis, and it certainly isn't engaged. At -1 or 0, then the baby at 0 definitely is engaged. If the baby is +1 or +2, then that baby is very low down in the pelvis, and usually the mom is feeling a lot of pressure. It's just if you had a question about what SP -3 means, it's just referring to how low the baby is in the pelvis. So we're going to talk a little bit about ways to help ripen the cervix, because a ripe cervix, from my experience, I've seen that it leads to a faster birth. And generally most women like the idea of a faster birth versus a long, drawn-out labor. Now, in the European research, omega-3 oils and consumption of omega-3 fish has not shown to speed up labor or ripen the cervix, but in general, the European research is showing that women are having fairly fast labors. What I'm finding in our culture in southern Ontario is that women who are consuming omega-3 rich fish and or fish oil throughout the pregnancy generally have quite a ripe cervix by the time she gets to her due date, and that's a good thing. So the omega-3 oils are really important for your baby's brain and eyes, and it can also help with a very ripe cervix, which also leads to an easier birth. Braxton Hicks contractions, as we mentioned before, help ripen the cervix, because what they do is they retract the longitudinal fibers that are in the uterus and essentially pull the cervix up into the body of itself. Intercourse, because there's prostaglandins in semen, so that will help ripen the cervix. Nipple stimulation will also do that. Acupuncture. Acupuncturists very familiar with the points to avoid and that help bring on labor. So generally speaking, they stay away from those points. Then once somebody's 37 weeks, then those points can be lightly stimulated with acupuncture and with acupressure points. So that would be something to talk to your acupuncturist about. And the acupressure points like spleen 6, large intestine 4, those kinds of things can help bring on just more uterine contractility that will help with ripening the cervix. And there is some research out of Iran on the topic of eating dates. I believe the recommendation is 6 dates a day from 37 weeks on, perhaps the last month or so. And so we're talking about the dates that are fruits. Avoid dates that may have been sweetened with additional honey or other sweeteners. So you just want the regular dates. Based on this Iranian research, shows that women have faster labors. Sweeping the membranes, I'll talk about that in a bit. That can also help ripen the cervix. In the old days, they used to do it fairly routinely every week from about 37 weeks on. The risk with sweeping the membranes is that it could accidentally break the amniotic sac, and that's something is best avoided. Certainly, sweeping the membranes can do quite a significant job of ripen the cervix and bring things to a better state in late pregnancy. There's almost no research on evening primrose oil, and the little bit of research we do have isn't promising. It actually shows higher rate of complications. I'm not a naturopath, I'm not a nutritionist, I'm not anybody with any designation in that regard, but I did see a lot of women use evening primrose oil throughout pregnancy when I practiced as a midwife. And evening primrose oil, when used throughout pregnancy, can be very helpful in ripening the cervix. So neither evening primrose oil nor omega-3 oils bring on labor, they just help ripen the cervix. Bringing on labor would be other kinds of oils like castor oil. Oil of the castor bean can start contractility and start labor, but omega-3 oils, evening primrose oil, just help ripen the cervix. They don't start labor. So here we have a diagram of sweeping the membranes. So healthcare practitioner is doing a vaginal exam. The cervix needs to be a little bit open, and essentially what they're doing is kind of running a finger inside the cervix and separating the amniotic sac from the inside of the cervix. So I use the word separation. They're not attached in any way, but you're just kind of loosening that up, perhaps in the same way that you would maybe loosen an ice cube before getting it out of the tray. So just running a finger gently, loosening that area between the amniotic sac and the cervix. It's a procedure that can be fairly quick. It's an office procedure. It's not that difficult to be performed. Generally, most women will comment on that it's painful, so that can happen. And generally, you can expect to have some bloody show with that because there may be some stretching of the cervix that goes on with that. generally just stretch some of the capillaries in the cervix and release some blood. So it's blood that's from the cervix in the mom's body. Some women tend to have a little bit more, some a little less. So that's what a stretch and sweep or sweeping the membranes is. Most healthcare providers don't do that these days, so if you do want this, then you would have to talk to your healthcare provider about getting it. A lot of them tend to prefer to wait till 39 completed weeks. So if you get this done at 39, 40, and 41 weeks, if you're still pregnant at 41, these stretch and sweeps or sweeping the membrane can go a long way to really ripening the cervix. If a cervix is very, very, very ripe, a stretch and sweep can put somebody into labor that day. So I've seen that happen. That's something that you would want to talk to your healthcare provider about. In my experience, red raspberry leaf tea does zip for ripening the cervix. But if you like it, then you can go ahead and drink it. It won't do any harm. Spicy food, driving in a car with bad suspension on bumpy roads, those kinds of things. You know, if somebody's really right on the edge of going into labor, then, you know, maybe spicy foods or going for a bumpy ride, that may put her into labor. But for the most part, if those things work, then we're seeing them being used a lot more, but they generally don't make a difference. Okay, length of early labor. So in general, length of labor for first baby in Southern Ontario is about 38 hours. We're looking at 20 to 24 hours for early labor, which is the mild stuff, 12 hours for active labor, which is more intense, and then 2 hours for pushing. A lot of women are pretty surprised when they hear that early labor can be that long, 20, 24 hours. For some women, it's a couple of days. So it's really, really, really important to manage this part of the birth. Because if somebody's not getting very good sleep, she's not eating well, she's not feeling very rested, and then the hard stuff starts, it's really hard to deal with that. Bearing in mind that it could be 20, 24 hours, it could be an hour, we don't know. If by the time you get to your due date, your cervix is very thin, say it's 100% effaced, your Bishop score is very high, it's unlikely that you'll have 20, 24 hours. It might be 2, maybe 4 hours, something like that. So you'll have a short early labor. If somebody gets to her due date and the cervix has had very little change to it, it's long, firm, rigid, then it's likely she's going to need that full 24 hours. I've seen women go 3 days and 3 nights in early labor, and then the hard stuff starts. And trust me, it's challenging. It's really difficult to deal with. So just a reminder, early labor is warm-ups. Once the cervix is thin, then active labor starts, then it starts to open. So, in terms of timing them, we time contractions from the beginning to the beginning. So if they're every 5 minutes and lasting a minute, you would be having 4 minutes of a rest period. So say if you were writing down the start times at 12:05, 12:11, 12:16, those would be the start times of the contractions, the beginning of the contraction. You would then use a second hand to determine how long the contraction is lasting. Loads of apps available these days apparently to time contractions, so you could take a look and see what's available online. And just to know that you're not expected to record all of them. If something's going on for a long time, 20 hours or so, nobody expects you to keep a track of all of them. We'll talk about the mucus plug for a little bit, and we'll get into more about just the contractions of labor and how to deal with that. The mucus plug can pass in late pregnancy, it can pass in early labor, it can pass in active labor. Typically, you may notice it on your panties or your pad or when you wipe with a bathroom visit. Mucus plug is normal. It generally is quite stretchy, like stretchy egg white, or if you've ever been checking your mucus for your cycle, it would look like fertile mucus. If it's clear, then there's no blood. If it's brown, it would be old blood. If it's pink, it's just a little bit of fresh blood. If it's bright red, it would be a lot of fresh blood. And as I mentioned earlier, the blood is coming from the cervix. All normal, all expected, what's supposed to happen. So as we see from this diagram, when the cervix has length to it, the mucus plug has a place to sit. And when the cervix gets really thin, there's no place for it to be. It just won't stay there, so it just gets released. So a mucus plug being released, all that means is there's been some contractions that have pulled on the cervix in some way. It's jostled the mucus plug, it's released. So releasing the mucus plug just means something is happening. It doesn't mean labor is happening. It can mean something, it cannot mean something. I've seen women lose a mucus plug and then 2 weeks later you lose another one. So it's just one of those things that is just information. A mucus plug, sometimes referred to as bloody show. The mucus plug, if it's bright red blood, it's coming from the capillaries being stretched as the cervix opens, and that's a good thing. Bright red bleeding with a mucus plug generally means the cervix is being stretched open, and that's something that we like to see. You may notice in active labor, if your midwife or nurse or physician does a vaginal exam, that there'll be blood on the exam glove, and that's normal. That's to be expected. Mucus plug forms in pregnancy in part by skin cells on the inside of the cervix just sloughing off, and they just sit there. And it's the protection actually for the baby from any infection or bacteria. And as I mentioned, it gets dislodged when there's uterine activity that has kind of pulled on the cervix in some way. Some women have a lot of bloody show, some have none. It really varies from woman to woman. If at any point you're worried or concerned, keep your pad or the toilet paper or just take a photo, contact your healthcare provider. So 511. So 511 is called kind of the rule of what to pay attention to. And we'll talk about this. Typically, prenatal classes will tell you that you're supposed to go to the hospital when you've got 511. And 511 refers to contractions that are every 5 minutes. They're lasting for 1 minute, and that's been going on for an hour. So if you've had contractions every 5 minutes lasting a minute for an hour, typically in the prenatal classes or physicians will tell you to go to the hospital. So your obstetrician, your family practice doctor, prenatal classes will tell you go to the hospital when they're 511. You will be assessed. They'll do your vitals. They'll listen to the baby's heart rate. They'll do a vaginal exam. And then they'll send you home. Unless there's some other reason to keep you in the hospital, 511 is not labor. It's warm up. So just to know that if they're every 5 minutes and that's lasting for 20 to 24 hours, they're not keeping you in the hospital. You're being sent home again. So in general, I'm seeing a lot of women, they do prenatal classes or maybe they read a book or somebody tells them, their physician or whoever says, show up when they're 511. They do. They get sent home and then they feel like, now what do I do? Because they're not keeping me. I'm dealing with something that feels like labor, and some women feel pretty abandoned, actually. So a large part of this presentation is to help you understand how to deal with this part of the birth, because if you've been sent home or your care provider has said, that's not labor, call me when things are really happening, you need to know what to do. So if your physician has said to you, come into the hospital when they're 511, then what you might want to do at 36 or 37 weeks is ask your doctor then, okay, so knowing what we know now about my pregnancy, that I'm low risk, everything's looking good, is it acceptable to come into the hospital in active labor? Might be helpful to ask your doctor this, because I'm seeing a lot of physicians tell women come in when they're 511, and the women do, the nurse assesses them, they get sent home again. The doctor's not getting hauled out of bed. The doctor's not losing a night's sleep, having to deal with this. The parents are. The parents are up for hours, driving to the hospital, parking, getting in, thinking something's happening, then being sent home again. Really important, if it's just regular 5-minute apart contractions, first baby, that you actually get some sleep. And we'll talk about how to do that. So you want to make sure that your physician is giving the all clear to stay home if they're every 5 minutes, and that you can come into the hospital when they're active labor. If you have a doula, the doula may come to you if they're every 5 minutes. So that'll be something you talk to your doula about. Midwives. So the midwife may tell you to call when they're 511. Generally speaking, your midwife won't come and assess you or ask you to come and be assessed. Early labor is not labor. This is warm-ups. We'll be going over what to do, how to get your rest, that kind of thing. So either you're slowing things down, maybe you're speeding things up if you can't get your sleep. You want to manage this part of the birth so that you're going into active labor and feeling like you've got some good energy. Your midwife may tell you to contact her when they're 411, so every 4 minutes, lasting minute for an hour. Again, she may come and assess you. She might ask you to come into the office to be assessed. In general, she will be wanting you to contact her when they're closer together, when they're 3 in a 10-minute window. Having said that, she will likely want to know if you think the bag is no longer intact. If there's bright red bloody show, she may want to know that, and certainly if you're worried or concerned. These are all legitimate reasons to contact your midwife, and if you have a physician, to contact your physician. So, getting into the part of how to manage early labor, this is important to know. And there's lots of different ways to do this. You want to ignore early labor as much as possible. And there are many ways to do that, but if it's nighttime, you need to be getting your sleep. If it's daytime and you're capable of napping, then I would strongly recommend you get a nap, because it's quite likely that you'll be up all night with strong active labor, and the more rested you are, the better. There are many ways to cope with early labor. Getting into a bath and having 4 more cups of Epsom salts can help slow labor down, and that's generally a good thing. Getting into a shower. A lot of midwives will recommend Gravol. So you want the regular Gravol, not Gravol ginger. And the side effects of Gravol are drowsiness. So you want that drowsiness to help you get some sleep. If you have any melatonin and you respond well to melatonin, then you may want to take some melatonin instead. Or if you've got a prescription for diclexin and you generally find that causes drowsiness, then you could take some of your diclexin. Alcohol use is controversial more and more these days, but certainly from my era, it's very common for midwives to tell a mom in early labor to have a glass of wine or some beer to slow things down. And certainly more women these days using hypnosis or relaxation find it's really helpful to get onto a recording to help with getting some sleep. In general, we want dark, quiet, and undisturbed. That helps with the production of oxytocin. Mammals who sleep at night generally go into labor at night. Mammals who sleep in the daytime generally go into labor in the daytime. So humans, for the most part, will start labor at night, and that's just a normal response to how our hormones work. So you want to boost oxytocin production. And ways of doing that are cuddling, kissing, fooling around, dark, quiet, relaxing, those kinds of things. The other things that you can do are just getting busy. So if it's daytime, you may want to be baking, cleaning up, packing your bag, going for a walk, those sorts of things. And you want your partner to be staying at home. If your partner needs to leave you for any reason, then it's generally a good idea to have a friend or your doula or somebody else be with you at this point. So the more you can ignore early labor, the better. If it's nighttime, you need to be sleeping. That's where you'd be doing your medications, your Gravol, your bath, that kind of stuff. Daytime, get busy. Just the more you can ignore it, the better. For partners, it is really helpful if you can find a way to just be calm. The calmer you are, the more helpful that'll be for her, and to help her remain calm, rested and nourished. Remind her about ways to get sleep, to be eating, sleeping at night, napping in the daytime. Meals that are easy to digest, and avoiding any stinky foods like sausage, garlic, onion, that kind of stuff. And for partners to remember that when women go into labor, their sense of smell is heightened, so you may want to avoid eating stinky foods and make sure that you have toothbrush, toothpaste, breath freshener on you, because if you're helping her with doing some breathing and stuff like that in active labor, fresh breath can be really helpful. You may run her a bath, maybe throw some Epsom salts in the bath, get her supplements to help her with sleep. Of course, you're at home now, so even though this is warm-ups, it's important that she's not completely on her own. You may want to make the bed, and generally we recommend that you have the good sheets, the fitted and flat sheets on the bed, then some kind of plastic or protective coating on top of those sheets, and then put another fitted sheet on the bed so that if the bag breaks or messiness happens, then it's really easy just to peel off the plastic in that fitted sheet, throw those into a bag. The bed's already made. So making the bed this way now, that if you are, say, leaving for the hospital or the birth center, it's really easy to just pull off the plastic in that top sheet, and then the bed's already made for when you come home afterwards. Packing the last few things in the bag, any arrangements that need to be made for childcare or pet care, or if you have a toddler already. This may be a time to just take some pictures, just to kind of commemorate this in some way, just so that she will be able to look at this afterwards and just see, just some of those moments of what it was like where things got busy. You may want to write stuff down or record it in your phone or in some way, shape, or form. What she's eaten, when she's eaten it, when she's had sleep, amount of sleep she's had, that kind of thing. Because you'll be asked these questions by the midwife or the nurse when you're with the healthcare provider. And then it's your job to contact the healthcare provider when active labor starts. Contractions. So we've got two columns here, and the column on the left are the kinds of things that will help you sleep through the contractions. So if the contractions are every 5 minutes and you're sleeping through them, that's a good thing. If you can't sleep, if you're woken up every 5 minutes, then you're going to want to move to the column on the right that will space contractions out. So getting into a bath or a shower, especially using Epsom salts in your bath. So it could be a full tub bath. It could be a foot bath as well if you don't like tub baths. If for some reason you can't take a bath. Then Epsom salts are magnesium. Magnesium relaxes muscle tissue and will relax the uterus and space out the contractions so that instead of every 5 minutes, they'll be every 10 minutes, 15 minutes, maybe every 30 minutes. Getting some more magnesium either by supplement or magnesium oil. So taking magnesium by supplement, of course, will also help relax the bowels. And if you've been doing magnesium supplements in pregnancy, your body's probably used to it. If you haven't, then you may prefer to use magnesium oil, which is a product that's called magnesium oil. You can get in the health food store, and you just put it on the skin so it doesn't affect the bowels, doesn't encourage loose stool or diarrhea. Wine or beer will space out contractions as well, so alcohol will do that. So some combination of whatever feels like the most reasonable for you. Most important to get your sleep, and if for some reason you can't get your sleep, then you may want to just encourage more contractions. Again, this would be something to talk to your care provider about. But the first step, I would say, is just try and get your sleep. Just get some, maybe run that, sit in a bath for an hour with your Epsom salts, take your Gravol. That may do whatever needs to be done to help get some good sleep. If you've never had Gravol before, if you've never taken Gravol, you may want to take a small dose, say maybe 25 milligrams or even smaller, at 36 weeks before bedtime. Just see how your body responds to that. Most people do well with Gravol, but some people just have a poor response. So you might just want to double check what your response is in late pregnancy. So as you think about what you want to be doing in early labor, in your baby's birth, how you're going to manage getting sleep, how you're going to go about your day, these are important things to think about. Maybe you want to write that down, maybe review this again and take a look, and maybe talk to other women, maybe ask your childbirth educator, your healthcare provider, what is recommended for getting through this part of the birth. So once early labor moves into active labor is generally defined as 3 contractions in a 10-minute window. This is when you're definitely contacting your healthcare provider, and you'll be making your way to the hospital if you're planning a hospital birth. If you have midwives and you're going to the birth center, then typically the midwife will come to you first and then make that decision to go to the birth center. If you're having a home birth, the midwife will come to you, of course, at this part in the birth. If you have a midwife, you always contact your midwife first. You don't just show up at the hospital or the birth center. She needs to know about that in advance. But 3 in a 10-minute window for a first baby is generally about 12 hours on average. For a second baby is 8 hours. So you don't need to, leave for the hospital at the very first sign of 3-minute apart contractions. Usually you have a number of hours that you're be dealing with this, but 3 contractions in a 10-minute window is generally what we consider active labor, and that's the real stuff. So just to recap, we're talking about low-risk term births. Early labor is managed with your partner at home. And early labor is lengthy, 24 hours for first baby, and it can be on and off for days or even weeks for second or subsequent birth. So often women will talk about having 5-minute apart contractions for hours at a stretch, sometimes for weeks prior to the birth starting. So that's normal, not considered unusual in any way, shape, or form. So really important to manage your energy, making sure you're getting good sleep, you're eating, you're relaxing, and when you're getting into active labor, that you're feeling well rested. And you may want to use this time to connect with your partner. Things will get busy with active labor and once the baby is born, so use this time to connect and spend some good time together. And dark, quiet, calm, and safe is really essential for making more oxytocin. And as the body makes more oxytocin, oxytocin is one of the important hormones of birth, and oxytocin is what gets the uterus contracting. So the more oxytocin we have, the more the uterus is contracting. And with natural oxytocin that your body makes, it also encourages your body's natural anesthetic, your body's endorphins, so that you'll be getting greater comfort. So I hope this was a helpful presentation. If you have any questions or comments, you can contact me at Sean@ChildbirthJoy.com or 416-255-8333. I welcome your feedback and comments, and thank you for listening.